A COVID-19 vaccination policy for healthcare facilities. A presentation by Cheryl Henderson and John Lohman, Liberty University Leadership, Policy, and Ethics, December 12, 2021. COVID-19 caught the world flat-footed, including leaders in healthcare. Social media, cable news, government officials, and anti-vaxxers filled that void, sometimes with propaganda and fear. That led to healthcare workers resisting a vaccine proven to save lives. This policy uses evidence-based information to outline vaccine safety and identify disease threat while injecting some choice into the discussion inflamed by partisans. This presentation defines our COVID-19 policy for all healthcare employees, not just nurses. The goal is vaccination of more than 90% of all staff members while allowing proven science-based exemptions. All employees and contractors in this facility, from EMS and nurses to housekeepers and CEOs, shall be vaccinated against COVID-19. Nurses and other healthcare workers are required to have numerous vaccines for school, clinicals, and employment, and this policy follows more than a century of United States vaccine mandates and the safe administration of more than 8 billion COVID vaccines worldwide. This policy is written completely by nurses with years of real-world experience in every major hospital department, from ER and the floor to ICU and advanced practice. Healthcare workers, especially nurses, are taught to think critically and not just to blindly follow. And we recognize that rigid mandates without individual consideration or accepted science leads to feelings of restricted freedom. As with all other aspects of this policy, we address vaccine hesitance and exceptions with the latest peer-reviewed information. The health and safety of patients and their families are the top priority of healthcare providers. As of the writing of this policy, vaccines are proven to be the most effective prevention to the spread of COVID-19. In order to implement this policy, vaccinations will be staggered in 7-day increments among departments to decrease absenteeism related to expected side effects. Employees will be paid for one 12-hour shift in the 48 hours following each of the 2 initial Moderna or Pfizer mRNA doses. Severe reaction is extremely rare, but if any should occur, allowable hospital copays will be waived and the employee treated without charge beyond their insurance coverage. Meetings will be held in each department 3 to 5 days prior to vaccination events to explain the policy and answer any questions. Any employee with further concerns is welcome to contact their department head to help schedule one-on-one counseling on accurate, current information to alleviate any doubts. Knowledge and communication are key to this policy and to controlling COVID-19. There are a few viable reasons not to take the COVID-19 mRNA vaccines, and instead of blindly trusting government-issued information, we consult the latest peer-reviewed sources and recognize those reasons. Associates with a documented allergy to ingredients of the vaccines, with documented anaphylaxis to previous vaccines, or with a written physician provision are exempt from this policy of vaccines. Further, employees with PCR-documented COVID-19 infection may wait up to 6 months from the date of initial diagnosis to be vaccinated. Immunocompromised employees, those undergoing chemotherapy, or pregnant women will be vaccinated based on the advice of their physicians. Associates who are not vaccinated are required to wear a surgical mask at minimum at all times while on the facility campus. They also must accept a reasonable reassignment within their scope of practice when demonstrated as necessary by their supervisor or when a patient requests a vaccinated employee. Employees and associates who conscientiously object and choose not to vaccinate without an exception are welcome to separate from the company with a recommendation based on their work performance. They may be eligible for rehire once vaccinated or if a better COVID-19 prevention is found. This policy follows precedent of more than a century of U.S. vaccine mandates. Those mandates have been repeatedly upheld by the Supreme Court and by proven medical sources. The public good of well-developed vaccines, many of which were protested early on in their development, has never been successfully disputed. The U.S. Centers for Disease Control and Prevention has for years routinely recommended vaccine against 16 diseases from birth through age 18, including diphtheria, mumps, tetanus, pertussis, polio, rubella, and measles. Children are not generally allowed into public or private schools without those vaccines, except in cases of medical or sincere religious reasons. The U.S. Supreme Court in 1905 upheld a Massachusetts law requiring residents to receive a smallpox vaccine, stating that such mandates are part of the public's right to be protected from the threat of preventable disease. That case stemmed from an 1809 law mandating smallpox vaccine. The U.S. Supreme Court also upheld mandated inoculations for school children, and in 2002, a federal district court declined to support vaccine exemptions based on religious beliefs. Nurses and many other medical personnel are historically required to have numerous vaccines, including 3 doses of hepatitis B, 2 doses of MMR, 1 dose of Tdap, 1 dose of varicella unless infected as a child, plus annual influenza shots. Titers are regularly taken and supported with vaccines when needed. Vaccination against COVID-19 is an important continuation of those measures designed to protect patients, employees, and their families. Part of the argument against COVID-19 vaccines outlined by anti-vaxxers, some in the media, and partisan politicians is that the disease is not a real threat, that it's just like the flu, even if it's a real disease at all. The truth is, worldwide, more than 5.2 million people have died of COVID-19 and COVID-related complications. More than 780,000 Americans have died in that same period. COVID-19 is a serious, serious disease. Perhaps the most shocking statistic of all, COVID-19 is currently the 3rd leading cause of death in the United States, behind heart disease and not far behind cancer. It bears repeating. COVID-19 is the 3rd leading cause of death in the United States. Worldwide, more than 8 billion, that's billion with a B, COVID-19 vaccines have been given, with hundreds of thousands more given daily, with a minuscule number of severe reactions. According to metadata, among the first 17.5 million doses of vaccine given in the United States, 66 anaphylaxis cases were reported. That's fewer than 4 reactions per million. A secondary, more critical study indicates severe reactions at between 2.5 and 11.1 cases per million doses of mRNA vaccines. That's an average of 6.8 per million, most often in people with a history of anaphylaxis. However, this policy does not ignore that negligible possibility, instead making provisions for even the most unlikely of reaction events. In this policy, we recognize there are common physical reactions to the mRNA vaccines, including arm soreness, fatigue, headache, low-grade fever, and cold-like symptoms, and we provide for those expected reactions. Beyond that, lack of confidence and understanding, fear, and resistance to enforced mandates are main drivers in hesitancy toward COVID-19 vaccines. Among 1,205 nurses responding to a 2021 survey, a lack of confidence in vaccines, fear of infection caused by vaccines, and a lack of understanding of the potential severity of COVID-19 infection led to hesitancy to both COVID-19 and influenza vaccines. Public trust and the feeling of restricted freedom are among factors in international resistance. Historically, vaccination programs have been very effective in eliminating diseases once considered dangerous or fatal. Because of that resounding success, some younger people have limited experience with many communicable diseases, leading them to believe risks are minimal. Anxiety and language barriers also are factors in vaccine hesitancy. We address those in this policy. People who do not trust public institutions are less likely to trust vaccines. In general, when people believe a medication is safe and effective, they are willing to take them, including vaccines. Mixed messages from political figures and other leaders can exacerbate that problem, which was an issue for vaccine-hesitant medical students in a recent survey. Students also pointed to unknown or undisclosed side effects as a reason for delay. We address those in this policy. This policy does not attempt to hide side effects or possible severe reactions, instead relying on disclosure and evidence-based, peer-reviewed science. Educational curriculum is needed to enhance knowledge and teach medical students and nurses about COVID-19 vaccines and how to properly counsel others on vaccines. Studies supporting this policy use the latest evidence base designed to decrease doubt and increase accurate scientific knowledge. Those studies will be made available electronically to all who wish to read them. Counseling is offered to explain side effects, expected reactions, and signs of severe reactions. We combat the current objectionable forced or fired vaccine mandates with the nurse-reviewed evidence before injection policy. The APRN and DNP must actively engage in developing and implementing health policies using peer-reviewed information. They must also help create that peer-reviewed information. A main argument against mRNA vaccines is that they are too new or were created too quickly. In fact, such inoculations have been researched since the 1960s. They've been used for decades to assist the immune system in targeting specific cancer cells. mRNA vaccines against other diseases have been developed for more than 20 years. Yet another argument is unknown side effects years down the road. While no one can ensure anyone's health years down the road, it is known that, historically, serious side effects from any vaccine, including mRNA, occurs within 2 months. The Johnson & Johnson vaccine uses a more traditional vector virus method, introducing a non-live version of the pathogen instead of an mRNA trigger. A study released on November 2, 2021 indicates the Janssen vaccine is about 74% effective against COVID-19 infection. While Janssen vaccination and boosters are acceptable, this policy encourages the more effective mRNA vaccines. Overall, current COVID-19 vaccines are 74 to 95% effective in reducing symptomatic COVID infections and are more than 95% effective in reducing severe COVID-19 infections. While breakthrough cases are noted, the fully vaccinated with high levels of antibodies against COVID-19 are far less likely to be infected. Vaccinated people who do become ill are far less likely to need hospitalization, and mRNA vaccines remain the most effective prevention of COVID-19 infection. Health and safety of patients and employees will always be our priority, but we also hope to ease any fears or concerns over vaccines and this policy. As outlined earlier, APRN-trained supervisors will visit with each department as groups ahead of vaccines and will be on hand during vaccine events and will be available for one-on-one discussion before and after vaccination events. To combat any language barriers, this policy is published in English, Spanish, Filipino, and Vietnamese to reach the widest possible audience. Other languages will be accommodated as needed and recognized. COVID-19 infects and kills the patients we see most often in healthcare facilities. The older the person, the worse the potential disease devastation. It is proven substantially more virulent among people over age 50. Those over age 65 are at the highest risk of severe infection, lasting effects, or death. The highest per infection rate of death is among those over age 75, our parents and grandparents. While they must protect themselves, healthcare workers must do all we can to ensure their health while in our facility or while sharing our community. Some questions have arisen about the COVID-19 Delta variant and now the Omicron variant. Delta infected a higher percentage of vaccinated people for several reasons. First, there were a higher number of vaccinated people when Delta manifested. Second, masking and social distancing waned by the time of Delta. And third, antibodies, or our internal protection from both vaccines and infection from the disease, are shown to decrease within 6 to 8 months. It is hoped boosters given 6 to 8 months after the last COVID shot will last longer. It's important to note that the higher pool of vaccinated people, the less likely variants become. Among all ages, unvaccinated people are 45 times more likely to be infected with the Alpha variant and 40 times more likely to die than those who are vaccinated. Unvaccinated people are 13 times more likely to be infected and 20 times more likely to die from both the Alpha and Delta variants. There is a financial cost to implementing this policy. Although the vaccines themselves are obtained at no charge to the facility, they must be stored at sub-zero temperatures and administered within a few hours of opening. 2 nurses per department will be paid for 6 hours at $40 per hour to administer vaccines in each department during each vaccination event. 1 nurse leader per department, HR employees, and a counseling facilitator will be trained for 8 hours each at $40 per hour. The facilitator will oversee all pre-event department sessions and will be available during all vaccination events at $60 per hour. Regardless of the number of employees, the process is feasible and interruptions in patient care can be minimized by giving vaccinations at morning and evening shift changes and staggering them among departments in 7-day increments. That allows more nurses and caregivers in the float pool to cover shifts in other departments. All vaccinated employees will be given 1 12-hour paid shift off 1 or 2 days following their vaccination to allow comfortable recovery from any possible side effects. In that very rare event of severe reaction, hospital copays are waived and the employees treated with no out-of-pocket costs. Healthcare is our responsibility. We took that on long ago when entering the level of medical training we chose. The nurse's ethical pledge of non-malfeasance to first do no harm applies to COVID-19 and the care of those most at risk. It also applies to management in this case, and we are trying to use the best possible information in making decisions. Doing no harm means allowing exceptions and providing for training, counseling, and recovery time. Whether we admit it or not, we all were a little afraid when COVID-19 caught us flat-footed. We now are armed with ways to prevent or at least to curb its effects. Management and employees at all levels share the ethical responsibility to do just that. Doing nothing is not an option. In general, nurses and other dedicated healthcare workers follow guidelines unless there is a viable reason not to. That loyalty and independence are part of the backbone of best practices. There is an ethical imperative for nurses to be involved in development and implementation of sound healthcare policy. Through no fault of any one person or department in particular, healthcare partially abdicated our responsibility to government and the media during and since the 2020 lockdowns. COVID-19 and vaccines are not political issues. They are healthcare issues. nurses must now overcome politics and propaganda to accurately redefine the narrative into one of patient advocacy and effective self-care. As much as bedside nurses are responsible for patient advocacy, APRNs are responsible for that, plus the best interests of all healthcare workers, leadership in our facilities, and the good of our communities. APRNs are the top tier of nursing and must not lose our firm grasp on this or any other healthcare issue. Leadership is always important, but even more so in a crisis. The transformational leader recognizes resistance, addresses valid concerns, makes appropriate concessions, and continues moving forward. That sometimes requires innovation and a step back to look at the bigger picture. In this case, that meant using evidence to alter some arbitrarily rigid rules. The lockdowns and surprises of COVID-19 are behind us. We have recovered our footing and must continue advocating for the best policy, even when there is opposition. We base this policy and other decisions on the best interests of patients, subordinates, students, our families, and the community. We combat fear with facts, propaganda with truth, politics with policy, and the unknown with faith. As Christian nurse leaders, we combine compassion, empathy, and education with faith, integrity, and responsibility. We apply our legitimate and referent influence to guide the best care for patients and fellow nurses. Democratic leadership means sharing responsibility and listening to those around us. We look inward and outward, setting strong examples while respecting differences, and this COVID-19 vaccination policy is designed around those principles. We base our decisions on science and on faith. God gives us the ability to help, and we are to be His hands, feet, and voice. Advanced practice nurses are to be credible, honest, and growing examples of caring and hope as we lead our departments, facilities, communities, and country from crisis to healing.